Hello and welcome to Patient-Centered GA Care, a synergistic approach to optimized management. I'm Dr. Stephen Ferrucci, Chief of Optometry at the Sepulveda VA Ambulatory Care Center in North Hills, California, and Professor at the Southern California College of Optometry at Marshall B. Ketchum University. I'm joined today by my friend and colleague, Dr. Nathan Steinle, retina surgeon at California Retina Consultants of America in Santa Barbara, California. Today, we will be discussing case studies that focus on the diagnosis and referral of patients with GA secondary to macular degeneration, along with monitoring disease progression and adverse effects. Welcome, Nate.
Oh, thank you so much, team, for having me. What an honor.
Thanks. So what I'd really like to focus on is when, as optometrists, should we be referring patients for the new FDA-approved GA treatments? So that's what really want to kind of pick your brains about today. So let's imagine I have a patient that's coming in for his 6-month follow-up into my optometric office, and he's got a few extrafoveal geographic lesions, both eyes, but his vision is still 20/20. He's concerned about his vision, and maybe he's saying he's having a little more difficulty reading and driving at night. Um, First of all, I guess, what tests do you think would be helpful to decide if a referral is indicated?
Oh, that's a great question. I think we all see these patients all the time who are frustrated with their vision, and sometimes it's hard to figure out if it's, anterior segment disease or if it's, ocular surface disease or if it's truly a retina problem. And in our clinics, we typically would do two imaging modalities, and that would be a fundus autofluorescence, and then we'd also would do a OCT, a spectral domain OCT. Those are kind of the two hallmarks for us. So an FAF and a SDOCT. You can get color photos, but sometimes color photos can be difficult to interpret, and the fundus autofluorescence just makes the pathology jump out for sure.
Yeah, that sounds true. I agree with you. Sometimes those early smaller lesions you can really miss on color photos, and you can really pick them up beautifully on either OCT, the on-FOS OCT, or the FAF for sure.
Totally agree.
Fantastic. So I guess if we feel that we are going to send that patient over to you for a consultation, what information would you like to see before we send them over to you?
Yeah, great question. So, I do like to see if you can send some type of past image. And, it doesn't have to be the whole binder because I know there's a tremendous amount of volume of data now that we collect on patients. But, any past image you have, whether it be a color photograph from years ago, or especially if you have fundus autofluorescence, it seems like the wide field fundus autofluorescence have really become, quite ubiquitous across eye care. And if you have an old image, that's very helpful, or even an old OCT, because a lot of the OCTs have that near infrared imaging on it, and that one image can really help kind of guide therapy. Because what I'm looking for, and the same thing you're always looking for in your clinics, is progression. And what we want to say is this patient really actually moving forward with their potential geographic atrophy, and an old picture from a year ago or 2 years ago or 5 years ago is extremely helpful. Then we kind of know how we got to the present images.
Yeah, I think that's a good point. So if I just saw this patient and it looks stable, when do you think I should see that patient? If the non-progressing seems stable, when do you think I should see that patient back? Or is this something that you'd want to see, or you think I could follow it up myself?
I certainly think you could follow it yourself. I would say 6 months and then repeat the exact same imaging. And one point to the listeners, and I'm sure you do this in your clinic, is try and image patients on the same machine. It's always like when I have a patient go get an MRI or a CT scan, I say go to the same scanning place and have the same radiologist read it because you want the same reproducibility. And so in our clinics, if you got a fundus autofluorescence last time or an OCT last time, try to do those same imaging again on that same machine, in that same office, so that you can have that good reproducibility to make sure you can see those subtle changes that could happen over a 6-month time span.
Yeah, it's a good tip. I've never thought about that. What if I have the guy come back in 6 months and now I'm noticing that there is a little progression and it looks like it's getting a little closer to the foveal center in one of his two eyes. You think that would be an appropriate patient to send over at least for a consultation?
Yeah, I think that's definitely a good time when you see documented progression and the patient is starting to get symptoms. I think that's a great time to at least start the discussion. We know with these anti-complement drugs that are now the approved therapies for geographic atrophy, that earlier treatment is better, and they work over time. And so that at that point, I think that'd be a great time for referral.
Sounds great. How soon do you think you need to see a patient like that? I mean, I don't need. call and wake you up in the middle of the night, do I?
No, it's a great question. I think we've all gotten a feeling now that geographic atrophy does move more quickly than we thought, but it's by no means an urgent consult. I would say within the next 6 weeks would be a reasonable time frame. Sometimes you have a more, the patient makes the disease more urgent because of their anxiousness, and that's totally great to put that on the referral note, and then we can try and squeeze that person in a little bit earlier.
Yeah, that's a good point. What do you think would be a good discussion for us to have to that patient as an optometrist before sending them over regarding the potential treatment?
I think my practice has really shifted. And I've been out for 13 years now. And when I started, it was really, general ophthalmology based, and now it's really optometric based. And I think that we dovetail so well with optometry. So I think first off, I would just make sure you reiterate that you are the primary eye care doctor, and absolutely critical that the patient comes back to see you on a routine basis for glaucoma management, for refractive needs, for anterior segment disease, and that you're sending to the specialist for potential therapies. And I do like it when at least patients know the therapy is at the two FDA approved therapies we have now are both injections in the eye. And at least that concept has been given to the patient. And of course, a lot of times it's shock up front and worry up front. But at least they know that's what the road we're on right now is. There's no oral therapies. There's no light therapies. It's just simply an intravitreal injections are the therapy of today.
I think that's a good point because these might be patients that I've seen in my optometric practice for a long period of time, and now finally I've decided that it's time to send them over for a referral. And I think us telling them what they might expect and that they might get an injection, I think kind of helps you guys out. I mean, they've never met you before, and the first thing you tell them is, "I'm going to stick a needle in your eye." So I think a little consultation ahead of time goes a far way for sure. If the patient already lost vision in one eye from geographic atrophy, and now I see progression in the other eye, is that something I'd want to send a little bit sooner, or you still think that same time frame holds true?
Yeah, I mean, I think and you know this too. Each patient is so different, but I think I would a little bit phrase it to the patient that we now have therapies available and see how interested they are too, because we actually need a, a motivated patient to get the treatments too. But if you have a motivated patient, I think that's a very appropriate time for referral. What's your opinion on that same patient?
Well, I think, if you've already lost vision in one eye, then I want to be uber protective of the second eye. So I'm probably going to be even a little more cognizant to send that patient over. But I do think we have to explain to patients that, this is not a panacea. This is not going to restore any vision they may have already lost. And that, the goal is, moving forward to hopefully slow down the progression. But I think that's really important. Otherwise, they're not going to follow up and they're not going to keep up with their appointments, I feel. What about a patient that's already had bilateral loss with subfoveal geographic atrophy? Are there times you think those patients are still appropriate for treatment, or is it frankly too late?
Yeah, boy, that's a big discussion in our world right now is bilateral GA with already subfoveal involvement. And I do think there's room for therapy here. First off, it gives the patient hope. There's always a good deal of anxiety with any type of eye disease, but especially geographic atrophy. And so at least the patients feel like they're taking every measure to reduce the amount of vision loss possible. And then second, it keeps that patient in the system because who knows what's around the corner. And so that perhaps someday we have even better therapies, and at least that patient's used to treatment at that point.
Interesting, interesting. Do you have any thoughts about what makes someone a good candidate or perhaps not a good candidate for treatment?
Yeah, great question. So, in general, it takes a somewhat motivated patient. So, people who have, it's kind of interesting from an insurance standpoint, they're very covered drugs. So, that hasn't been much of a discussion. But instead, it's been more about the ancillary support and what kind of ride support they have and how close to the clinics they live. And so, these are in general, much older patients. And a lot of them are no longer able to drive themselves. So I think people that have a motivated family member or a care team provider that will actually help get these patients to the clinics for their injections. That's a key marker for success for these patients. And then finally, people that have kind of realistic expectations to make sure that, this isn't going to get any better, but our whole goal is to slow down those hands of time to reduce that vision loss over time.
Yeah, that's a good point. Treatment burden is a real issue, especially say in our older patients that may already have some vision loss that perhaps can't drive themselves. It's a real issue. So that's for sure. With any, unfortunately, with any treatment or any therapy, there's always potential adverse effects. What are some of the potential adverse effects that we should be looking for in a patient who's on these treatments for GA?
Steve, that's a really great question. So, one of the things I try to really harp on when I give any lecture to anyone that's not just a retina specialist is when you now see a new uveitis patient in your clinics, I think one of your routine questions you should ask that patient is, do you get intravitreal injections? Do you get eye injections? Because sometimes patients don't associate the uveitis with an eye injection, and they won't always be forthright or don't even think about the fact that they, come in to get their glaucoma check or their glasses check, and they don't really think about the injection they got 10 days ago or 12 days ago. So I think one question you should put in your Rolodex of questions for uveitis patients is, do you get intravitreal injections? Because any uveitis you see in a patient who's had a recent injection is always endophthalmitis until proven otherwise. So that's always by far the number one worry we look at. And with these drugs, with it being anti-complement, there's a lot of concern up front whether or not reducing the immune system would perhaps lead to increased rates of endophthalmitis because you're kind of somewhat locally immunosuppressing the patient. And thankfully, the trials have not borne that out whatsoever. That the rates of endophthalmitis with both of the FDA approved therapies are the same as they would be with any other type of anti-VEGF therapy. So that's a thankful, worry that we don't have to exaggerate. And then the other thing we really watch for, and was shown in the phase 2 trials and now shown in phase 3 trials, is that conversion from dry to wet macular degeneration. And so in these patients, do watch them kind of closely for a conversion from dry to wet. And that is a dose dependent phenomenon. So it's dependent on the number of doses the patient's gotten over time. So the more doses and over more time, a higher rate of conversion from dry to wet.
Interesting. Fantastic. Any advice you'd give to optometrists regarding communication with a retinal specialist when they're thinking about sending patients for treatment with these new GA drugs?
Yeah, it's always a key question. How do we communicate quickly and efficiently? If you can include one image, I would say the fundus autofluorescence and older autofluorescence would be the best image we could ever have. A second one would be a near infrared from an OCT from a year ago or 6 months ago or 2 years ago. That's really helpful. And then second, I would say, what's this patient's visual needs? What are they really struggling with? Is it driving? Is it reading? Is it walking? Just so we kind of have an idea of what that patient's looking for in their life, so we can kind of guide them as far as their expectations.
Yeah, it's interesting. I didn't think about that last thing, but that's really important. What's their goals of treatment, right? What is it that they really want to get from this? That's actually very important. Any closing thoughts you'd like to share with our listeners today?
Just first off, thank you for the opportunity, and then second off, it's really an exciting time. How many years have we all been discussing and studying dry AMD, and now we have not one but two approved therapies for patients, and it's an exciting time that we can at least give hope. And there's many different research companies looking at other avenues of treating, geographic atrophy and slowing down dry AMD. And it used to be the part of any retina meeting that no one wanted to go to because there wasn't much hope on the horizon. And now there's many different avenues and many different shots on goal. So it's exciting. We have two therapies now, and stay tuned. I think we might be having another one of these discussions in a year or so.
Yeah, I hope so. But I agree with you. It's a very exciting time because for years we couldn't offer our patients with GA or dry AMD really much or any hope at all. And now we can. So it's an exciting time. And I agree 100%. And I want to thank you, Dr. Steinle, for the excellent discussion today. And thank you for listening. Please remember to take the post-test and evaluation to receive CE credit and to tune in for additional episodes within the podcast series. Thank you again.